Many thanks, Dr. Wasim, for inviting me to conduct this panel discussion. First of all, let me tell you all that we chose this topic deliberately because this topic of choosing the concurrent drug as a part of CTRT regime in head and neck cancers is a much less discussed topic. While we all use it very often, we use concurrent CTRT in our practice. And I think with the very good deliberations by the two speakers, Dr. Sahu and Dr. Sarbani, I think a lot of issues have been already cleared. But further going, we will answer some of the practical issues which still come to our mind while we treat these patients with concurrent CTRT. So to begin with, I would like to invite my panelist, Dr. Pooja Nandwani. Dr. Pooja Nandwani is a radiation oncologist from Sterling Hospital, Ahmedabad. Dr. Kanika Sood Sharma, Senior Radiation Oncologist from Narayan Hrudayalaya Hospital, Delhi. Dr. Bhavna Narula. Dr. Bhavna is a consultant pathologist at Max Hospital. Dr. Milli Datta. Dr. Milli Datta is a consultant radiologist at Max Hospital. Dr. Ajit Gandhi, I think he'll be joining us shortly. He's from Lucknow, RML Hospital, Lucknow. He's again a radiation oncologist. Dr. Partha Sarthi, Senior Medical Oncologist from Narayan Hrudayalaya, Delhi. Dr. Lalit Mohan Sharma from Bhagwan Mahavir Hospital, Jaipur. He's again a consultant in medical oncologist. And Dr. Devrat Arya. Dr. Devrat Arya is a medical oncology consultant at Max Hospital. Apart from the panelists, we also have our experts. Just in case we are not reaching any conclusions or we are not at the right page, then we have two experts to further guide us. That is Dr. Kumar Prabhash and Dr. Sarbani Ghosh Laskar. We all know them very well. So I think with this, we go ahead with the presentation. Give me a few minutes. Neerav, have you given me rights to share the screen?
Just a second, ma'am. Yes, ma'am, you have rights to share the screen, ma'am. Sure.
Ma'am, take your time.
Madam, slides are visible. Good to go.
Yeah, they are visible. They are visible.
Madam, you need to unmute yourself.
So we took 3 cases for discussion. In case
Yeah,
you have
you are audible.
Okay. So we have 3 cases for discussion, and all these cases are, and the issues that we've put here are real without any modifications. And I request you all that if you have any concerns, questions, please put them in the chat box so that they can also be discussed. So I'm straight away coming to our first case. It was a 53 years old lady. She had no comorbidities. There was no history of any addiction also. A very well-educated family, very well-educated person. And she was basically investigated for pain and irritation in throat, which she was having for 4 months, and she had a neck swelling, which rapidly appeared in a month's time. So this was her clinical finding. When we examined her, she was well preserved and she was in good performance status. She had, I think we have to request all the audience to please mute themselves. So on clinical examination, she was in good performance status. There were bilateral neck nodes palpable at level 2. The right lymph node was bigger than left. In oral cavity, her oral dental hygiene was good. There was no ankyloglossia, no trismus, and there was a big growth sitting in the right tonsil extending to the base of tongue and the vallecula. Laryngoscopy also the same finding, and the biopsy from this came as moderately differentiated squamous cell carcinoma. So I would like to start first with Dr. Pooja Nandwani. My question to you is that in such a patient, she's a non-tobacco user. There is no history of smoking. It's a oropharyngeal carcinoma. So do you do P16 testing routinely in all your patients, and in what proportions do you actually get a positive result?
So, ma'am, a case of oropharyngeal carcinoma, a patient who is a non-smoker, definitely we would think for the P16, and we advise for P16 every patient of oropharyngeal carcinoma. Mostly it is done by the IHC technique, and on an average, what percentage of patients come out positive are around 30 to 40% in our cases.
May I ask Dr. Kanika the same question?
Dr. Kanika, you need to unmute yourself.
Am I audible?
Yes, please.
Yeah, so oropharynx, practically we are ordering P16 for all patients, considering it as the surrogate marker for HPV. Barring a few where we do not have access, sometimes if somebody is carrying something from outside and we do not have access, these are the situations where we do not have the information. And I spoke to my pathologist, what are our rates? So surprisingly, she was first of all astonished. She said oral cavity patients are more tested at our center than oropharynx because samples are more available because they're operated with us. But by an average, she said it is around 25 to 28%, which we are finding positive in the samples we are testing.
Dr. Lalit Sharma, any difference in practice?
Yeah, in fact, routinely we don't do that because our pathologists feel that ISC is not the perfect way to test for HPV. And we have asked for RT-PCR, which is some validation part is yet pending. But some of our resident in DNB had done a thesis that we documented 18 to 20% of P16 positive with IHC method. But still, my pathologists are not fully comfortable to say that it's a surrogate marker for HPV.
So I think we find that there is a lot of difference in practice. There are centers which are regularly doing it. There are centers which are not yet regularly testing P16 across for all oropharyngeal patients. My another question to Dr. Kanika, Dr. Pooja, and Dr. Lalit is that is there any subgroup of patients or any particular clinical finding where you would say that you are expecting more HPV positivity and you would certainly ask for that test?
So, ma'am, shall I go first?
Yeah, please.
So, any patient who is having a bulky node, a small primary but a bulky node, who is a non-smoker, a young patient, definitely our suspicion for HPV positivity would go there. So, in such patients, we would definitely ask for a P16. Regarding other group of markers, as far as now, we are only doing P16 for these HPV cases.
Any different, Dr. Kanika?
Ma'am, we agree with the same format. Younger patients, good affluent, non-smokers with disproportionate nodes in comparison to the primary, we would definitely think would be clinically a positive HPV we would test.
I think I'll add just one point here that I find that the nodes which are very cystic, when I examine, I feel that the nodes are like lymphoma nodes and not like hard nodes of squamous cell carcinoma. That also becomes a point of suspicion. So going further, I would like to ask Dr. Kanika and Dr. Pooja again, the same set of clinicians, that do you see that HPV positivity same across all oropharyngeal subsites like base of tongue, tonsil, palate? Are they equally positive or is it any different? And probably you can also share your experience about testing it in oral cavity, larynx, and nasopharynx.
So, ma'am, as of now, in our setup where I'm working, we are not asking for HPV positivity except in the oropharyngeal one. So, I would not be able to comment on the second part of the question. And even on the first part, I am not sure about whether there has been some difference in the rates of base tongue and the tonsil for the P16. I'm not sure about that.
So, ma'am, those are also not segregated in terms of the site specificity, which site has more HPV. But as I told, I spoke to our pathologist. So for the oral cavity, they are analyzing that somebody is doing some work on it, and she has quoted that around 35% at least in our subgroup, she has found HPV positivity in oral cavity. Rest of the sites, site-wise, we haven't divided site-wise as of now.
Dr. Sarbani, we'd like to hear from you your experience at TMH about HPV positivity. in oropharyngeal
got two
cancers as well as other sites?
Yeah, so we actually typically do HPV by P16 because the concordance rates are quite good actually, and that's actually it's a recommendation to do P16. But of course, when there is doubt or when you suspect clinically that could be P16 positive, but you're not getting, or you have some doubt, then you should go do the RT-PCR, and we are in the process of actually validating the RNA scope also. The other thing is about the other sites. We have data to say that oral cavity around 20% or so, even in the in all sites that we looked at from our own data from Vedang's publication, it's about 20%. In Behel's paper, it was about 22% for the oral cavity. Hypopharynx, larynx, nasopharynx, there is data available about HPV, but the exact effect on prognosis is not very well understood. There is equipoise in literature across the other sites, except for the oropharynx. And at TMH, what we typically do, Kumar would also agree with me, patients who are getting treated in TMH, we definitely do P16 in all comers with oropharyngeal cancers. Of course, in the Indian subset, what we see mostly is base of tongue. See, the tonsil is expressed as a primary site essentially in the Western data, whereas in India, besides having lower HPV positivity rates, what we also see is that the predominant oropharyngeal subsite is the base of tongue, the palate, and not the tonsil. I have never heard of the vallicula ever mentioned in any of the Western literature, whereas that's something that we see very typically. And of course, just now, Ashwini's student is in the process of doing a thesis, and about 630 patients of oropharyngeal cancer. Amongst the patients who had HPV status available, it is only about 12.5% who were HPV positive. So that's the kind of data that we have. But if you ask me whether we should be doing it, my response is yes. Pooja knows that very well. And that simple reason is that if we don't have our data, tomorrow we really won't be able to do anything. And it's not about just positive, negative, or changing treatment. We need to have data on our patients too.
Sarpani, so far we've not been doing P16 testing for other than oropharyngeal malignancies. So what is the reason why we should be doing it only for the data generation, or I mean, as a routine, we don't do it?
Yeah, so I think that what literature typically mentions is, see, I think all this emanated from Carol Factory's first paper and from Chaturvedi's data on the rising incidence of oropharyngeal cancers, whereas all the other head neck cancers were coming down. And that was attributed to some extent to the decreasing use of tobacco and the increasing other habits, So I think that's how the oropharyngeal and HPV, and then there was a very strong correlation, especially in the US. And soon even the European countries have caught up, though first the data from Europe was of course much lower than what was available in the US. But now if you look at both the continents, the data is kind of matching. Now, why we should not do it for the other sites, I think it's just essentially, see, for us, it's a problem first to do it even in oropharynx. For the US and the other Western countries, it's, the other cancers are not so much their problem because they don't see so much of larynx, hypopharynx, or oral cavity. So I think that's the main issue. But if you ask me, should you do it? You could under a protocol setting, but I don't think it could become routine because we are not even doing it for oropharynx. So that's my take on it.
Dr. Vineeta, I think another interesting point would be the usage of P16 by IHC as a surrogate of HPV positivity in different subsites, right? And I think the robust or the main data comes from oropharynx, and the correlation between P60 and HPV positivity in other subsites, including oral cavity, is much lesser. So while most data is to the tune of 85-90% in oropharynx, other sites, oral cavity is probably 20%, larynx is about 40%.
Right, I agree with you. So I think let's hear out from our pathologist also. Dr. Bhavna is there with us. Dr. Bhavna, I think you routinely do P16 testing by IHC for testing for HPV. Are you happy with it or not? Do you think it's a robust test, or can there be inter-institutional differences in reporting, in validating, in all those things?
So IHC by P16, since we've all discussed, P16 is a surrogate marker for HPV. It is easily available, and IHC is a very, very sensitive test to the tune of 95 to 100%. That's the sensitivity of P16. and the specificity is also to the tune of 85 to 90%. So P16 is routinely done in almost all labs, in all the cases of oropharyngeal carcinomas. And we do have the controls which are run simultaneously. The internal control is the squamous epithelium. All the basal cells and the parabasal cells of the normal squamous epithelium from which the carcinoma arises are P16 positive. And we do have proper external controls also, in which we take tonsils as an external control.
I think the problem lies with the reporting. When do you call it positive?
We call it positive when it's a diffuse block positivity. That means it's a diffuse nuclear as well as cytoplasmic positivity, and the percentage of the cells has to be more than 70%.
Okay, very well said.
So, Dr. Vineeta, can you allow me for a question? At my center in Jaipur, I'm working at Mahavir Cancer Hospital in Jaipur. So, my pathologist feels that P16 is just a screening method, and the RT-PCR is short, and they have raised question that the validation also needs some scraping from the oropharynx or like that. So, is that true? There are pathologists also, Dr. Bhavna and Dr. Kumar also can probably throw some light that which is the P16 by IHC is good or RT-PCR is the best?
P16 is the test which is routinely available in all the laboratories, since IHC is a very easy process and it is done in almost every place. So that's not an issue. Regarding the sensitivity, as we've just discussed, since the sensitivity is also more than 95%, so we can easily do IHC for P16, which is a recommended surrogate marker for HPV. As far as the other tests are concerned, when there is a discordance and when there's a clinical and pathological discordance between the P16 result, then we recommend confirmation by other methods. And for confirmation also, the ISH is the standard method. The gold standard is ISH rather than PCR.
Dr. Kumar Prabhash, any comments?
I agree with the comment, except emphasizing that you need to convince your pathologist that P16 is good to start with. You can do subsequent things. In fact, becoming but it is very good to start with, because whichever way we have analyzed P16 expression, there are now 3 data sets, one by Vijay, another was by Vedang, and one more was analyzed by, I'm forgetting the person. P16 correlates very well with the outcome, so it is good to do it.
Thank you.
Dr. Bhavna, one more question for you. Are there any morphological features which make you suspect that this could be a P16 positive case?
Yes, ma'am, there are certain morphological features. First of all, the morphology of the HPV positive carcinomas. It is not a keratinizing squamous cell carcinoma as we commonly see. It is a non-keratinizing morphology. It can be basaloid or any other non-keratinizing morphology, which we are likely to report as high-grade carcinomas. So one is non-keratinizing morphology, and 2, when a non-keratinizing tumor, which is squamous cell carcinoma, and it comes out to be P16 positive, then we also do not do any differentiation or grading score on that case.
So very well said. I think we've heard from clinicians when to suspect HPV positivity or when to do it. We've heard from a pathologist perspective. Now coming to the radiologist. Dr. Millie Datta is there with us. Dr. Millie, are there any imaging features on MRI by which you can also, think that this patient is likely to be HPV positive?
HPV positive tumors tend to be more enhancing, they are exophytic, they are better defined, and they have more propensity to demonstrate cystic nodes. Whereas HPV negative patients are likely to be isoattenuating lesions with ill-defined infiltrative margins, and they have nodal necrosis instead of cystic nodes. Like cystic nodes are the ones which show thin capsule, which is like up to 2 mm and has predominantly fluid attenuation without any solid component within, whereas the necrotic node would have thick irregular margins with nodular component.
So I think Millie has already answered this question. The second question which was there for her, actually when we read these papers, we also started getting confused as to what is cystic and what is necrotic, because to our eyes actually they look similar. So as she has correctly said, that cystic nodes are these nodes. They have very thin enhancing capsule. homogeneous fluid content, no internal irregular solid areas. While this node is more like a necrotic node because there are thick solid walls with irregular central low attenuation or hypoattenuating areas. So I think it is important to identify these factors even on imaging. So I will say that I will just try to summarize few things here, and Dr. Sharbani and Dr. Kumar Prabhash can correct me if I'm wrong somewhere, that Western data reports much higher positivity, HPV positivity in oropharyngeal malignancies to the tune of 28 to 68%, but majority Indian studies have shown much lesser incidence of about 15 to 20%. And within India also, there is wide variation in the rate incidence of HPV positivity. For example, Dr. Pooja is quoting a higher percentage positivity. Similarly, Northeast areas have a higher positivity as compared to the rest of the India. The positivity is known to occur more commonly in tonsil rather than other subsites of oropharynx. There is also a 5 to 20% positivity report from oral cancers, laryngeal and hypopharyngeal cancers also. And CAP guidelines recommend that in reporting, we have to ensure that only diffuse cytoplasmic and nuclear staining of more than 70% in the tumor cells is considered positive. And in case there is any discordance, the discordance in Indian population is generally because of the use of tobacco in our population. And IHC, as Dr. Kumar Prabhash has just now said, convince your pathologist, start with this test because it has a high sensitivity and moderate specificity. And clinical features that all of us have understood are patients who are non-tobacco users, females more commonly, early T stage, small tube primary with large neck nodes, cystic nodal metastasis, non-keratinizing tumors. These are the patients where we should be focusing. So now coming back to our patients where we started from, 54 years old lady who had presented with tonsillar lesion. Dr. Millie, we have her MRI images if you could read out for us.
There is a large enhancing mass involving base of tongue bilaterally, extending into the glossoepiglottic fold and involving the epiglottis and the right AE fold. There are bilateral enlarged necrotic nodes.
Okay. So I will ask Dr. Kanika and Dr. Partha Sarthi, maybe that is staging for HPV positive versus negative tumors as any different according to the new AJCC staging?
Yeah, so as per the new staging, the T as well as N have undergone changes. In terms of T, there is no division into T4A and T4B. So it's just the T4, which combines both. And I think in N, there's a major change. Like we were initially having N1, N2, and N3. So we practically are now just having N2 and N1, and the size criteria of 6 centimeter has been attributed to N1 as well as N2. So that brings in a downstaging. So whatever was a higher stage, maybe somewhere between 4A falls down, something which was into 3 falls down to 2. So definitely there's a change. In pathological staging, I think it is number-based. The nodal numbers, whether less than 4 or more than 4 are accounted for when you are designating N1 and N2 categories.
So these are the major changes. Already summarized it very well, that we need to do the HPV testing to know the correct stage for our patients, because there is a different AJCC 8 staging for HPV positive versus negative patients. So our patient would fall into T3 criteria, irrespective of whether she's positive or negative. If she's P16 negative, then she would be N2C, which means her stage would be stage 4A. While with the same patient, if she turns out to be HPV positive, then her end stage will be N2 and her stage will be stage 2. So there is a huge difference. But the major issue is that do we do any treatment de-intensification or change in the treatment protocol based on whether she's HPV positive or negative? To start with, I would like to ask Dr. Partha Sarthi and Dr. Devrat Arya, any differences in the chemotherapy, drugs, choice, doses, NACT, anything from your side?
Yeah, so Dr. Vineeta, as of now, while we do know that P16 has a prognostic impact and will have, some impact in terms of how we can expect the survival is going to be. Unfortunately, as of now, there's no reason to modify treatment based on P16 positivity. I don't think there are any trials which have suggested that de-escalation of treatment has actually ensured that you can ensure equivalent survival with de-escalation. So in my practice, it's the same.
Any difference in the choice of concurrent drug that you would use, or any reasons to use NACT?
No, I think cisplatin, if a patient can tolerate it, remains the concurrent drug of choice along with radiation therapy. That's what the data suggests, and increasingly post the RTOG 1016 and the other study, clearly cisplatin is still scoring above cetuximab in terms of not only efficacy but with at times equivalent although different profile of toxicity. So no reason to change the medical oncology partner for radiation.
Dr. Partha Sarthi, any difference of opinion?
Yeah, actually HPV positive patients are not a homogeneous group. T4 and N3 nodes are not that good, even if they are HPV positive. And there is no change of treatment based on HPV till now. But this nimotuzumab data shows that it works rather well in the HPV negative subset. So if you are using weekly cisplatin, adding nimotuzumab in HPV negative will be a good option. If you are using 3 weekly cisplatin, there is no change in practice.
I didn't understand that.
Siri is saying that. It's not important that she understands it. Dr. Pooja, any change in?
So, ma'am, there's a lot of studies because we know that these tumors, they are more responsive tumors, and there are some studies which talks about de-intensification, like maybe in terms of radiation dose or even radiation volumes, or even trying some neoadjuvant chemotherapy and then reducing the radiation dose. But as of now, we don't have that much robust data that finally the standard of care gets changed. So still, till date, even if it is positive or negative, the standard of care is still the same, with cisplatin being the best concurrent chemotherapy if given the choice.
Yeah.
So I think we all understand that why we are doing the test is basically for generating our own data and maybe for prognostication. We know that it's unlikely making any impact on the treatment protocols for the patients, and our patient also, as expected, tested negative for P16. Now coming to the management, so this patient is a young patient. She has no comorbidities. She's PS1. She's planned for concurrent CTRT. So would you like to have any other workup or test before starting her on CTRT? And my question to medical oncologist, what is your choice of concurrent chemotherapy drug for her? Single agent, double agent, what would you like to give?
So can I respond to that, Dr. Vineeta? Lalit here.
Yeah, sure.
So I think single agent cisplatin is good enough for this patient, and we would like to do the kidney function test, audiometry for this patient, and then we go ahead with cisplatin plus radiation.
And Dr. Lalit, is it going to be a weekly cisplatin or 3 weekly cisplatin, and what doses are you going to use?
Weekly we give, and total dose we maintain around 200 milligram per meter square. At the major region, in fact, we also wish that we start giving 3 weekly based on other recommendations. But patients are commonly compromised, and many times they are deprived from nutrition, mucositis, weight loss, all those complications. So with weekly, we are happy to see them once a week so that the nutrition part and other things can be taken care of. We see most often very rural and illiterate population coming to us. So we are more comfortable with weekly.
Okay. Dr. Devrat Arya and Dr. Partha Sarthi, any difference of opinion, or you agree that it has to be a weekly cisplatin after doing pure tone audiometry and KFTs?
Yeah, and an echocardiogram in most of my patients. Yeah, PTA is although a little bit rarer, although guidelines do suggest that you should do it. I agree. While the data supports high dose cisplatinum, I think our practice has been to use weekly cisplatin at 40 milligram per meter square. I think toxicity, at least in our experience, which is non-randomized, appears fairly tolerable, and the logistics aspect is also in favor with a weekly cisplatin.
Any particular subgroup of patients where you would consider 3 weekly cisplatin, or not at all?
So I think this patient would probably fall in that subgroup. If she has no comorbidities, absolutely robust organ function, probably she is similar to the patient that we've seen who have been enrolled in clinical trials. I think it's also to do with institutional practice. But I think if anybody were to receive, she would be the one.
When I talk to a lot of medical oncologists, they say that giving 100 milligram per meter square cisplatin in single day is difficult, requires a lot of hydration. So how do you do it? You give it over 2 days, or you actually give it over one single day?
So I haven't done it. I do know that Dr. K.M. Parthasarthi has been doing it. So probably you'd like to hear it from him.
Sure.
And I think in most of the settings, whenever I've talked to colleagues and international experts who've actually done it, they've had the patient admitted. They've done pre-hydration for a day, post-hydration for a day. They've looked at electrolytes. So it's actually not a single day procedure. So they may administer it over a single day. I think practice in India is to split 100 milligram per meter square into 2 days. But I think nevertheless, irrespective of whether we split it or not, there would need to be a period of pre-hydration, post-hydration, which would mean that patient would probably be in the hospital for 2 or 3 days. I think that adds to the cost of treatment and also adds to the logistical difficulties.
Dr. Parthasarthi, your comments.
Now I am using my cisplatin as 3 weekly only for so many years. I'm not finding any difference, though the toxicity profile is different. And most of the trials have shown that you have to cross that barrier of 200 milligram to get that 200 milligram per meter square to get that good data of QR. So 3 weekly is still the gold standard for radical CTRT. In adjuvant setup, post the Japanese study, there is enough data that weekly can be a good replacement. But in radical CTRT, still 3 weekly is the gold standard. I am splitting my cisplatin into 2 days, and I am adding olanzapine as an antiemetic, and dividing over 2 days. They are tolerating well.
So as a radiation oncologist, I feel that whenever patients get mucositis, it is attributed to radiation therapy and not to chemotherapy. So majority patients, when they get mucositis, they'll end up in the OPD of a radiation oncologist. So let's hear from Dr. Kanika, who is a radiation oncologist working with Dr. Parthasarthi, about her comments on mucositis and other experiences with 3 weekly cisplatin.
So definitely, when 3 weekly came in, I was very, very apprehensive as to how our patients are going to handle the high dose regimen practically, because there were 2 factors. As already highlighted by Dr. Lalit Mohan also, our patients are usually very frail, not very nutritionally well maintained. But somehow the experience and confidence has built in over years. I think I've been seeing these 3 weekly chemotherapies in place for the last 6 years now. So surely there is an increased toxicity in the 3 weekly arm in terms of the nephrotoxicity and also leukopenia. So we were just seeing more leukopenia towards the 3 weekly arm, and we did conduct a small systematic analysis in a prospective fashion that how our toxicities are. I think I did share my set of toxicity pattern slides with you. So the mucositis hasn't been very significantly different, but the main difference we found is in the renal derangements as well as the leukopenia. But in a well-nourished patient where you have taken a dietitian into account and you have put a feeding phase well in time, most patients have completed the protocol within the timelines. I think we had equal, defaulters in the 3 weekly as well as the weekly, though slight mortality as per the analysis which we conducted was towards the 3 weekly arm.
So we would like to hear from Dr. Kumar Prabhash,
Yeah.
his experience of using 3 weekly cisplatin.
So we have used 3 weekly cisplatin in a good measure. Almost 30% of our patient takes 3 weekly. Previously used to be around 0. After this trial, we are giving more 3 weekly. We take many precautions when we do it, and we do give in 1 day. But all patients, they receive 3 days of hydration. It means that they do come for 3 days to the hospital, but they do come for radiation, but they do come for hydration. We do measure the electrolytes and RFT weekly, so they do come weekly. But again, I repeat, they do come for radiation, so that makes it a bit easy. So monitoring is intense. Weekly, all of them, they get a nutritional support, which is provided in a powder form. So we work in a government hospital, so you do understand resources available to our patients are different. So we do take measures. If you take those measures, then we are able to deliver. But again, one can question why not all 100%? The reason is, are we able to monitor? This is when we do have a resident and also
Dr. Prabhash, probably your connection is unstable. We keep losing you intermittently.
And can we have a poll till then? I think we have a polling questions.
I think we've lost Kumar Prabhash. Yeah.
Yeah. So the
Vaseem
third
sir, we
question.
display the third question.
Yeah. Thank you. Thank you. So third question, of this question again, which chemotherapy regimen has shown better outcomes in locally advanced head and neck squamous cell? So A will be 30 mg, B is 40, and C is 100 mg, and these all show same outcomes. So the poll begins now. So let us see what the attendees have to say, what the audience has to say, how do they do it, like do they give 30, 40, how comfortable they are with each regimen. I think that will be a very interesting to see, very interesting results. Something is wrong with the poll. I think, like, I don't know how many have answered this. I think 100% is 30 mg weekly cisplatin. I think there is something wrong. Nobody has answered. Nobody has clicked on option 2, option 3, option 4. So I think we'll get back to this answer of this question. Dr. Vineeta, you can carry on with your questions.
Dr. Vineeta, Dr. Sahu here. I just have one simple question to ask to my medical oncologist, Devvrata someone. With the weekly, as they are telling, and the dose intensity of 200 nearly needs to catch up with. That's where the cutoff is. So how many of the patients actually receive 6 to 7 cycles? I find that if you go for 5 cycles or below that, you are stuck. And if you're going for 30 milligram per meter square, the TMS schedule, you need to reach the 7 cycles. And if you have missed out 2 even because of some toxicity, then you are not touching the intensity. So how do you do that? And I have started to do the 3 weekly more often now. It is comfortable. The initial hurdle is there. The mental block is there. Then there are issues which Dr. Kumar and other Partha has told. That's the only thing. But otherwise, it's not that difficult to do. And I feel the electrolyte is the major concern rather than the the myelosuppression. And that's something, the sodium, you have to be very, very closely watching the sodium. That's where the real thing is all about. Anyone
Yeah, I agree with Dr. Sahu. I think it's a mental burden always, like giving somebody having a BSA of 1.8, giving 180 mg cisplatin is also a challenge. It's not that easy. And I think we maintain, we always give almost 7 cycles of cisplatin. And I always think that it's dose intensity, it should be 200 mg per meter square given, irrespective of whether you give 40 mg or 100 mg per meter square 3 weekly.
If I can make a point, so monitoring wise also, even if 3 weekly schedule is being done, I think as rightly said by Dr. Sahu, you continue to monitor the blood counts as well as KFTs weekly. It's not that the KFTs are monitored just prior to the chemotherapy delivery. So your KFTs as well as CBC, irrespective of whether you're giving weekly or 3 weekly, should be monitored regularly. That is one thing.
I think I agree with Dr. Sahu. I think there's a little bit of a mental block, and unfortunately, this is a global mental block. So this is not just mental block with us. This is what practitioners outside of India also do. In my practice, the dose is usually 40 milligram per meter square. So the critical number of cycles is actually 5. But you go based on data alone, I think there is also sufficient data to suggest that probably it's equally challenging, if not more, to achieve the cumulative doses with weekly cisplatin. So I would agree. I think the choice is dependent on our own individual practices and to some extent the kind of profile of patients that we see. So if you're going to look at younger patients, fitter patients, probably you should be doing high dose cisplatin a lot more often. But if you are practicing a setup where you have more elderly patients with comorbidities, I think to me that the choice is between a weekly cisplatin or target therapy, which most patients don't afford, and you end up using a weekly cisplatin or carboplatin in those cases.
Vineeta, can I make a comment here?
Sure, Dr. Sarpani.
Yeah, so now actually Kumar is I think he's not back online, but now actually if we are not doing the 100 milligram per meter square, we don't do the 30 milligram per meter square weekly alone. We're not doing that. We've now actually, if you're doing weekly, we are doing 40 milligram per meter square. And definitely in the nasopharynx group, we are definitely doing 40 milligram per meter square, because in that particular space, there is randomized evidence of 40 versus 100. So we are definitely, when we're doing weekly, we are doing 40 milligram per meter square. It's only sometimes in the relative contraindications where we are forced to give a lower dose of cisplatinum. We may want to combine it in the people who can afford it with nimotuzumab. So that's how we look at it. But we don't give 30 milligram per meter square cisplatinum alone now. We don't.
Agree with Dr. Sarban. Yeah, we our weekly and 3 weekly trial. Then that time we change. No, we do change, because once we do a study, we do change our practice based on what we had. So once we knew that the 30 was inferior, either we had to change all to 100, which was not possible, and so we did make two changes: more 3 weekly, and weekly we changed to 40. Yes, that's true.
Now coming to the next study, biologicals. So anti-EGFR therapy. So Dr. Devrat, Dr. Partha, Dr. Lalit, would you consider, have you started using nimotuzumab routinely in your practice? Your experience about its efficacy and toxicity?
Yeah, so I did go through the data with a lot of interest, and I think given the dismal outcomes with the current existing treatments for our patient with locally advanced head and neck cancer, I think we are all looking at some sort of escalation of treatment, and we've looked at addition of cetuximab, which unfortunately failed. We also looked at with some interest addition of cetuximab to carbo-5FU, but unfortunately the comparator arm was cetuximab in that GOTEC study, and now this study as well. I did note that at least in the trial, it did improve the DFS, the PFS, and the loco-regional control at this point, while OS appears numerically similar. I am keenly awaiting the mature results of overall survival, because to a lot of us, that's what matters. While the trial did suggest that the additional toxicities with the addition of nimotuzumab were minimal, I think although I don't follow this as a routine, I have used it in a couple of patients, or probably 3 or 4 patients. Unfortunately, our experience, especially with mucositis, wasn't that encouraging. At the same time, I think I'll have to say that probably the experience is too small to generalize this conclusion, and probably we need to use it more often before we can come to our own experience with terms of toxicity.
Dr. Partha.
Yeah, if you are not using 3 weekly because of any contraindications, if you are using weekly, then especially in HPV negative patients, this is a very exciting component. The data is very impressive, and especially in the HPV negative patients. So I will use it if the patient wants to go for a weekly regimen, or if there are any contraindication for the 3 weekly cisplatin.
Dr. Lalit, a quick comment.
Yeah, I also agree. And since most of our patients, they are coming from a low socio backup, so I'm not able to use it the way I want to use it. And HPV negative, of course, remains the choice. We have done study also of more than 50 patients with my colleague, Dr. Naresh Somani and team. So the data is mature for 4 or 5 years, and we were able to see some differences. I'm not having that paper in hand right now. So I would like to use it more often, but because of these reasons, not able to do so.
So Dr. Kumar Prabhash, coming to you, what is your experience overall, after treating these patients in the trial setting?
So the place to consider is, I think so, I agree with comments by all the panelists that when you're using weekly, that is where you one needs to consider. And second thing is where we are giving definitive chemoradiation, because adjuvant chemoradiation trial is on. The Singapore group is doing it. Dr. Iyer, who is the PI, he suggested that most likely by next year it should be done. So hopefully 2 years down the line, we should have the result. So one is weekly setting. Second is when we are using in definitive setting, that is where we need to consider. And third, and the most important, is the cost, which we should always have in the back of the mind when we give this treatment for these patients. So these are the three considerations for me. fourth, I totally agree that HPV, that was a postdoc analysis, but that was good data, because we went through in many ways to see that when we are putting in public domain how good it is. I totally agree that was a postdoc analysis, but it was reaffirming that there is somewhere the HPV negative patients, there is something this combination is doing, and similar was observed as was commented by Debrat in those European trial, where the comparator arm was inferior. But again, in those study also, majority of the patients were HPV negative. The way ours were, in fact, it was a bit less than ours, but far more than the RTOG studies. So suggesting that that can be another criteria if someone wants to use it. But for me, definitive setting and weekly cis platinum is the key. And another most important is the patient can afford it. And that's the reason majority of the patients we are not able to give it, but we do counsel the patients where we think it is useful.
Dr. Prabhash, but the point is that, if correct me if I'm wrong, that only 10% patients in your study were HPV positive. Rest all negative. So is it a good enough data for post-hoc analysis also?
Yeah.
To make this conclusion that it works well for HPV negative tumors?
Yeah. So two things in that data. One is that 10% is a whole group. It is not for oropharynx. Whole group. So that is expected, that whole group. If you have an oropharynx around 20% odd, then if you take larynx, hypopharynx all together, then it will be around 10%. Second is that data which was published for HPV negative was for oropharynx, was not for all other subsites, because that was too small in number. And we know that that is not what people want to listen today. We need to first establish that HPV matters in other subsites. So that was a part of the study of our collaborator from the basic science, which was there for whole HPV profiling, which was done. And that data which was published was one for oropharynx, and then it was for oropharynx HPV negative. So 10% is a bit erroneous here. There we wanted to point out, because without HPV, I think so every data today, if you want to publish, the reviewer does ask regarding HPV, and we had understood that, and it was a part of a collaborative study, but the data was there when we were sending our publication. So good, it was ready for us. But that's erroneous to
the design of the trial also. Could you answer those also? Why PFS was chosen and not DFS? Yeah.
So that is an important question. That PFS, why PFS was chosen? One will be, I'll give reasoning from the clinical point of view. Another will be from the designing of the trial point of view. If you take head and neck cancer, there are a few trials which has been based on overall survival, and there are multiple reasons for it. I'll come to that. So if you take chemoradiation trial in NEGM, only two randomized big trials done, both of them, PFS and local regional control, was the primary endpoint. Is there a reasoning for it? Two reasonings. One is that almost in 30% patients in head and neck cancer, the events, that is a survival event, is not related to disease. There is some other. What it means that, by and large, if you want to do your study, you have to put 30% extra patients if you want to do it, for overall survival analysis. Now, second more important point is, in head and neck cancer, and this is maybe again, my radiation oncology colleague will appreciate, and in cervical cancer, local regional control becomes important, and that is important for our patients as far as the symptoms are concerned when the disease comes back. May I give an example? Let me put this in number. If a patient, let's think about overall survival benefit is not there, that we don't know in this study, but in case, why in head and neck we consider it? If the patient has to live 5 years, if patient lives for disease free for 2 years, and a patient lives disease free for 4 years, does that make a difference? In head and neck cancer, it does. And that was the basis for it, for choosing the PFS as a primary endpoint. Let's see what happens in OS. I can't say for sure, but is the PFS good enough to have an impact? I can re-emphasize again for chemoradiation trial, and I will re-emphasize again with many radiation trials. where local regional control does have an impact. Should it be criticized? Yes, it should be, because we want OS is the gold standard, and we should keep emphasizing that. And that's the reason we can't say for every patient we should be using it. But yes, a PFS is a good endpoint, but not the best endpoint, and that should be emphasized. And we have discussed in our discussion section regarding this part of it. Also giving the importance of PFS and also criticizing that OS was not the primary endpoint.
So, Dr. Kumar, oral cavity and nasopharynx were two subsites which were not included in this study. So, how about using this drug in these two subsites? For nasopharynx, I believe that there are some Chinese studies of using nimotuzumab.
There's a phase 3 study on nimotuzumab actually in nasopharynx.
Okay.
So a small one, but I agree with Dr. Sarbani. It's the phase 3 study, and one can use it in their practice, not based on our data. We deliberately didn't include, because by and large we know that now nasopharynx to include collectively is a problem, so we can't include it. But one can use it. But I will re-emphasize that if you have a cisplatinum, don't leave it. That's the most important drug. Weekly or 3-weekly, we have more data for weekly in nasopharynx. There is a good randomized trial which was presented in ASCO as an oral. One should use it. There is data for carboplatin weekly. So till platinum, if you can't use it, sure, one should think about choosing this drug in setting. Oral cavity primarily treated by surgery, and this was definitive trial. So we hardly give chemoradiation in oral cavity. Sarbani is there, she may bear me out. And that if we give it also, we know that we are giving it palliative intent, and that's the reason we have not included. So there were 2-3 patients, but that also shows our practice.
Dr. Kumar, last question. I am sorry. Oropharynx, what do you recommend with this? So should one to add nimotuzumab to the platinum and RT should be doing a P16? And if it is negative, then it's worth giving it because it's a costly drug.
Yeah. So Dr. Sahu, I know you and me know it. All the data when we use in clinical practice, we use multiple things. There's no trial data which gets transcribed in clinical practice completely, and we all use our own filter. And I do understand where you are coming from, and I agree that yes, that can be one of those filter to be there. In the clinic, they say, hey, it was data for OS was not positive. It was a post-hoc analysis, but HPV negative was positive. That is far more reassuring for me. It is a costly drug, but no doubt about it. In this setting, so if I have to apply that filter, I'm for it, because I totally agree that for clinical trials to be transcribed in clinic, we all do apply filters, and we need to see which kind of filters we apply. And for this, HPV can be one of the filters. Yes.
Dr. Vineeta, can we have a polling question? Last question.
So I'll just complete this case. This case is just getting over. In fact, this patient who was seemingly very fit, no comorbidities, turned out that she had severe sensory neural hearing loss on pure tone audiometry, which we also don't do routinely, Dr. Devrat. We happen to do in her. So then we treated her with radiation, with concurrent weekly carboplatin and nimotuzumab, and we were very happy to use it actually. There were hardly any additional mucositis with the addition of the two drugs, and all manageable toxicities. I think now we go to the polling question. Dr. Vaseem?
Yeah, they will be displaying. So the question is, in HPV negative locally advanced oropharyngeal carcinomas, which treatment regimen would you prefer? Concurrent CTRT plus nimotuzumab, induction chemo followed by RT or CTRT, or D, none of the above? Your poll starts now, and waiting for the poll results. Yeah, so a lot of people, if you see it, look at this concurrent CTRT 33%, and I think 55% have started using nimotuzumab after this trial, have started adding nimotuzumab to CTRT. And some people still do induction chemotherapy followed by CTRT, and this is the results. So my question actually to Kumar Prabhas sir was like, when we have a cisplatin ineligible candidate, can we add nimotuzumab to the carboplatin? And are we how that is that justified or not?
So the good thing about our clinical practice is that we do have discretion to use the data in our clinic, and I think so we should never lose this. I keep saying to all clinicians, yes, this is one of the way to move forward. That if I had a patient with sensory neural hearing loss, and if I can't use cisplatin, what do I do? As much we think weekly cisplatin has lesser damage to the ears, it does have. We had a full review on this about it, so it does have it. And you do have a concern with the patients, and in that time, if only carboplatin, you have data, it is a iffy data. We have reviewed that carboplatin data. There is some positive data, but you have some negative data also. So you want to provide whatever best possible at that situation. So if I'm giving carboplatin, can I add some other drug which has got shown activity alone also? We know that there is a phase 2 randomized trial where this drug has shown activity, and I'm giving carboplatin. Why not add it and give it to these patients? So a lot of extrapolation of data here, but yes, we all do it, and that's important that we learn to do it. Those extrapolations, you're not going to get an ideal patient. What we do in trial, it doesn't happen. You're almost, one third or more of the patients will not be fitting in those trials which we talk about. So in that time, we do extrapolate, but yes, we should have reasonings how we went about it, and then we figure out what and how we are going to practice in our individual patients. And this is one way to see it, which I just saw.
Thank you, sir.
So quickly coming to case number 2, it's a 74 years old gentleman with history of tobacco use in past and with multiple comorbidities, including coronary artery disease and COPD. And he was investigated for bleeding coming from mouth. And clinically, he was well preserved but elderly, and he had bilateral big lymph nodes. Both lymph nodes were hard and fixed. And in oral cavity, there was a small proliferative lesion at uvula. So it was a small primary with a large neck node. Biopsy was standard squamous cell carcinoma, moderately differentiated, and P16 was negative. So this is how the MRI looked like. These were the big nodes. The largest lymph node on the left side in craniocaudal direction measured almost 5 centimeters. So coming straight away to the treatment option. So he's 76 with coronary artery disease, locally advanced disease, HPV negative. So the treatment options. I will start, I think, with Dr. Devrat Arya. RT alone, RT plus weekly cisplatin, any chance of RT plus carboplatin, any option of RT plus nimotuzumab in such a patient.
So I think this is clearly a very challenging patient. Age more than 70, and while performance status seems excellent, you're looking at comorbidities. I would also need to understand his other organ function, his social support. And while my go-to choice would to begin with be RT alone, if he has good social support, has minimal polypharmacy, minimal drugs, good organ function, that's where I may think of other option. In all likelihood, probably weekly carboplatin, nimotuzumab or cetuximab if he can afford it. Certainly not weekly cisplatin.
So the options are RT alone, or RT plus cetuximab plus or nimotuzumab.
You have mentioned weekly cisplatin also.
So Dr. Vineeta wants to ask, would you add like nimotuzumab to carboplatin, or if he's not even carboplatin eligible, will you give nimotuzumab alone?
Yeah, so if he is fit in selected cases, I will think about it. It's not a straight away no, but I think it has to be on a case-to-case basis. So every patient has to be, thoroughly looked into, because at 70 plus with CAD, even though PS is good, he is still vulnerable to toxicities of treatment.
Dr. Let's hear from Dr. Pooja once.
So, ma'am, as with all the studies, we have seen that RT alone would be preferably inferior result in this patient because he's a good performance status. So I think should be given a choice. And if we are a little bit dubious because of his age and other comorbidities, then I think RT plus weekly carboplatin would do really well in this case.
Dr. Sharbani, how would you treat this patient?
I think with Kumar, we would decide about doing something non-platinum based, and that would essentially be either radiotherapy alone or combining it with some of the anti-EGFR antibodies. And most often, this would actually be nimotuzumab if the patient could afford it. Kumar?
So I agree with you, Dr. Sarbani, except we'll add one more thing, which we now have a geriatric clinic, so we get it evaluated. And I request everybody, it's good to do it. We have learned quite a bit while doing it. And then it becomes a bit more reassuring whichever way we want to treat it. But I agree with Dr. Sarbani, will end up RT plus one of the biologicals or maybe carboplatin in this setting.
But
go ahead.
Can I just say something here? Maybe Vineeta, if this man cannot afford anything, any of the, or the concurrent chemo is going to become difficult, or any of the biologicals is going to become difficult, perhaps this is one site where we can exploit doing our precision radiotherapy with the SIB, because this may be a thing where altered fractionation can actually be exploited, considering that today we have the technology to do a better job about restricting morbidity. So I think this would be one place where we can do that in case he's not eligible for anything else.
So would you do accelerated RT or hyperfractionated RT?
So see, the classical teaching goes hyperfractionation, but if you can do acceleration without total dose reduction, that would be the other thing to do. Like, the 6 days a week, which also has some benefit. Now, see, in this man, we are actually talking about one thing is disease, curing the disease, and the other thing is also not giving him the morbidity of treatment, because unfortunately, he's got bilateral lymph nodes. So there is the amount of mucositis that you're going to give with any of the treatments is going to be sizable.
Ma'am, can I ask a question?
Yes, Dr. Pooja.
So, ma'am, my question one would be for Dr. Sarbani, madam, and one for Dr. Kumar Pravash. So, with this time-tested platinum group, do you think in this patient, just because he is 76 and we are a little bit skeptical, we can still go for nimotuzumab? Why not carboplatin? Carboplatin has a very safe profile in any ways. So that's the first question to you. And Dr. Sarbani, madam, you said for SIB, but these nodes bilateral and on the left side, they're almost about 5.5 centimeter. So even if a SIB and with RT alone, would we be able to have totally cure at this region, the nodal part?
So can I answer first, Kumar? So Pooja, this is where I want to take you back to McKinsey. So if you look at the McKinsey data, they talk about 2 parameters, and that is true even for altered fractionation radiotherapy. One is age and one is advanced nodal disease. So this is something that you need to keep in mind, and I'll let Kumar answer the carboplat question.
I agree with you, Dr. Pooja, that one can consider other treatments. I have given cisplatin to 80-year-old. So, but okay, can you say, tell me how many? Very few. But we have given it. So because this debate keeps happening in our clinic, we are now 4 people in the unit. So the moment someone thinks, okay, 80-year-old should be treated, then there is always a debate. Can we say every 80-year-old we don't treat it? And we have given it. So I'll say I don't rule out completely. It is just that many things we are seeing it here, but I'm sure we all know that we will evaluate this individually. One can deliver cisplatin 80-year-old. I assure you, if we choose the right patient, sure, one can. If one can't give nimotuzumab or striximab because of various reasons, then carboplatin can be considered. I don't say totally rule out in these patients, and because this is that first chance the patient has. We know that in head and neck cancer we don't have the second chance. We know that alone radiotherapy chances of complete response with having HPV negative bilateral lymph node looks fairly big, 3 centimeter plus. it is a bit tough. So you want to give some things, for a radiation sensitizer to see that if we can have higher CR rates, and then you do have some fair chance of patient having, long-term disease control. So I'm for it. What you are saying, Dr. Pooja?
I'd like to ask a question, Dr. Kumar.
Go ahead.
So at the Bonner trial, we looked with a lot of interest at the population subgroup of more than 65, where the addition of cetuximab clearly did not give us any advantage. I was also looking with some interest at the forest plot from the nimotuzumab cisplatin study. And so in your experience, how is the tolerability of nimotuzumab in an elderly subgroup, not necessarily 65, 70? And what can we expect in these population? Do you expect more toxicity? Because I think the fear is that while they may derive similar efficacy, is the toxicity which leads to higher mortality or morbidity.
So I agree with you, but let me put another data to it. So first one, McKenzie, and absolutely no doubt, McKenzie it does deter you from using systemic therapy in elderly. There is a very good SEER data which has come, and that is of I don't remember the number, maybe some 15,000, 20,000 odd. That's the number. And what they have done, they have analyzed two things. One is over the time period, use of chemotherapy changes in the elderly population, and also the outcome. And then the SEER data suggests that when they've used it, it looks like benefit may be similar. And that reminds me, Kian Yang comment that 70 of 70 is not the 70 of 2019 or 2020. So it is important to keep in mind. Coming third part of the Bonner's paper and our paper for 70 years, this is one of the problems that we enroll very few patients in elderly age group. That's the reason we also keep in mind it's not easy to deliver, but don't say no to everybody. We will be able to give the routine treatment what we give 50-year-old to 80-year-old, maybe in 20%, maybe in 30%. But remember, if we have a mind block, then maybe we'll be giving to 0%. Maybe that's not the best way to go. And this again I learned with my patient. I know his name now. He just now had recurrence. This was around 7-8 years back. And this man, after he very educated guy, almost 78-year-old with COPD, not a good COPD. He knew all the things about head and neck cancer, and he insisted with that. We had a big discussion with our radiation oncologist. I need to have chemoradiation because this is the benefit. We admitted him, and we said, okay. I challenged my resident. Hey, if you are a medical oncologist worth of a salt, manage this patient, and then say, hey, you can give chemoradiation. We did give chemoradiation, went into CR around 7 years odd, good. Now had recurrence, and now he's not doing good. So idea is that let's not club them together. More we try, then we are able to realize that we are able to deliver these curative treatment to these patients who are relatively fit. But I need to concede where we err, that becomes a challenge. So this was a success story, so I'm sharing. I do have my problems patients where I have given and then I have realized, okay, I will be careful next time.
I think so. That's why the point that you raised is very pertinent. Probably not every 70-year-old is an unfit patient. Not every PS170 is a fit patient. I think if you can't do a comprehensive geriatric analysis, at least some sort of geriatric screening should be put into practice before we decide for these patients.
So I just wanted to ask Dr. Sarbani, any word of caution when you're using nimotuzumab in this particular age group? Because in our limited experience, we get a lot of mucositis with nimotuzumab, especially this patient. So,
yeah, but Kanika, what I would like to say actually is our experience has actually been the other way. When we use cetuximab, we really see a lot of mucositis, and that mucositis is very different from the mucositis you get with cisplatinum radiotherapy. It's that red hot mucositis. Whereas with nimotuzumab, we've actually not faced any trouble. With mucositis.
Even with the doublet, madam?
Yes, actually, patients, that's why if you see the data, there's no difference in the mucositis and the other problems that we face otherwise with cisplatinum. So it's nothing different. Actually, that's why we were actually at a point in time actually wondering about how much nimotuzumab, because we were not seeing that kind of obvious toxicity. Because we've used cetuximab and we've reported our thing. Dr. JP has a paper on this about the Indian experience. And actually, compared to that, nimotuzumab is much more smoother sailing than, and of course, Kumar can say whether that's the case, even because they have handled these patients firsthand. But our impression as the radiation oncologist, we really have had no problems with the nimotuzumab group, actually.
I agree with Dr. Salbani. In the trial, there was a small difference, slightly more mucositis, but not a lot. But what I wanted to add is a majority of the time we end up using this drug when we use in single agent. We use in a compromised patient. I assure you, this again we have learned it a bit hard way. And compromised patient, if you give alone RT, and if you have a PS1 patient and PS2 patient, or PS01 patient and 2 patient, there's a remarkable difference in the mucositis. So I'm not saying nimotuzumab may not be contributing at all, but in case if you're using nimotuzumab in a compromised patient, majority contribution will be that compromised state. And again, that we have seen when we have seen our, we use some taxane, we use some little carboplatinum in these patients, these compromised patients, and then we realized they do develop a whole lot of more mucositis with less effective treatment also. And then you realize, okay, performance status becomes very important.
So here, because Kumar mentioned the taxanes, that's something that I'm really, taxanes are worrisome. But compared to that, nimotuzumab is better. But as he's correct, if you have an already compromised patient, your radiotherapy is also contributing. The compromised functional status of the patient also contributes, to your excess. But otherwise, really not.
So I think we just.
One question. We have a chat box. One question actually, and hyperfractionated arterial grain 20 fractions is also an option.
You, Vineeta, do you want to take that question, or should I?
Please go ahead.
Yeah. So see, Tanveer is asking that question, and my answer to you, Tanveer, is that the 55/20 is a typical UK regime where the volumes are very limited, and there you could perhaps, but then there is no clarity. These are regimes that are actually experimental, and they are actually very limited to certain groups who've been doing this kind of fractionation. But typically here, very often what they have practiced is NACT followed by RT alone and that kind of thing. But because 55/20, like what's being practiced on the hypno, which is being evaluated in the hypno, or even in the 65 in, that's a 2.75 in the UK trials, they again are very experimental. They are not the general of the run-of-the-mill protocol. So I think it would be a matter of individualization in these protocols, because here we don't have the answer. Now, 20 fractions, what is the kind of cisplatinum dose that you're giving? And your radiotherapy is 55/20, so it's a high dose per fraction. So the contribution of cisplatinum, both as with regards to the disease control, as well as the toxicity, both need to be kept in mind. So the word of caution there.
We actually treated this patient with radiation with IMRT and nimotuzumab 7 cycles, and he tolerated it very well. And on image guidance, we could see the disease regressing very well, and there was no problem of mucositis or hematological toxicity. Unfortunately, when he came on follow-up 2 months after CTRT, he had some chest pain and he had a cardiac workup done, which was found to be normal. And we ordered a PET scan. It showed complete metabolic response in primary and lymph node. But the surprise was that he had multiple bony metastases and few lung metastases. So the next slide is actually from Dr. Wasim, that what to do next. What are the options of systemic treatment here? Should we do anything? We gave him palliative RT for this rib metastasis, and he had pain relief. We gave him 30 grain 10 fraction, routine standard fractionated RT. So Dr. Devrat Arya, would you like to take this question?
Yeah, I think he has left. He's not here.
Okay. Dr. Partha Sarthi, this patient has failed very quickly. He's 76.
Yeah, here I think he's platinum and taxane naive. So we can use carboplatin and paclitaxel as a weekly with some dose correction. If you are carefully modulating the dose, he can go through that thing. Other option is that immunotherapy is also a reasonable option.
Dr. Vineeta, I also agree with the option of if we can do a rebiopsy and do some NGS, or otherwise also immunotherapy will be a better option other than the palliative RT and the symptomatic care, because we feel chemotherapy will be tough on him.
Dr. Kumar Prabhash or Dr. Sahu. Dr. Sahu, are you there?
So, okay. Go ahead, Dr.
Yeah,
Sahu.
sir. Dr. Kumar is here.
Okay.
So, first, was this expected? Usually, we don't want this to happen, but one of the important things to remember in head and neck cancer is majority patients, they come back in 2 years, and that is true. After that, people fail, but we have seen our graph from our hospital in head and neck multiple ways. We have seen OCAT, we saw in weekly, 3 weekly. It looks like they fail in 2 years. After that, failure happens, but it is few it happens. So it does happen. It becomes platinum refractory. Here it was nimetuzumab used, but if you use that connotation, almost 30% of them, they fail within those 4 or 5 months. As much we don't want it, but it is a fact of life. It happens. Only that we don't know which patient it will happen. So you always call it unexpected. What to do next? Too early patient has failed, so very disheartening. Intention will be palliative, that is without doubt. Do we expect long-term control? Unlikely. Disease has spoken itself that it doesn't look good. RT absolutely very important. Very good palliation one can get. Patient is always very thankful with those pain and other things which patient has, and RT helps them. Systemic treatment option. The only positive point for patient is that patient has not been exposed to platinum. So we do expect that patient having a chance to responding to platinum, is there in this setting, if they want, and that discussion needs to happen because patient has failed within 2 months or around 2 months. The discussion from best supportive care to to the immunotherapy, I think so. Whole spectrum needs to be discussed with them in detail, knowing that best supportive care as an option is there, considering the patient has failed within around 2 months or.
Yeah, and just last question, sir. Somebody have cisplatin refractory disease relapses within 6 months, like 4 to 5 months. What do you do? Like, do you go for nivolumab, or do you consider Erbitux, cetuximab plus chemotherapy?
Okay, so if the patient fails within 6 months, label-wise, cetuximab doesn't have a label for it. In fact, those patients were not included. Have we used it? We have used it. In those patients in the past, have they benefited? Yes, some patients do benefit it. What do we do today? If the patient can take immunotherapy, we do give them option for immunotherapy in platinum refractory. Good thing is that we also have option of triple metronomic, which we did a phase 2 study with 40% patient having responded to those treatments. So we have a good palliation, but not as good long-term control what we have seen with immunotherapy. But again, immunotherapy also benefits an early double-digit patient, not a big number.
Thank you.
So I will quickly come to the last question, and I'll come to the key issue in this case. So this was a 65-year-old gentleman, and he was found to have a carcinoma of the nasopharynx. It was a small primary nasopharynx. Dr. Millie, I'm skipping you here and directly, going to the management part. So he had a small primary in the nasopharynx. It was a T1 lesion, but there were large neck nodes. And we did a biopsy, nasopharyngoscopy, and PET scan from this, and biopsy was non-keratinizing squamous cell carcinoma. We did not do EBV testing and EBV titers in this patient. And I think I will skip all these questions. And he had one neck node which was below the cricoid cartilage. So we treated him with concurrent CTRT, and we gave him cisplatinum 40 milligram per meter square. Total 6 cycles were given, and we gave him radiation, the standard doses of 70 grain, 33 fractions, and so on, so forth. These were his volumes. After CTRT, before CTRT, patient's hearing was fine, but after CTRT, he developed moderate bilateral sensory neural hearing loss. And because of that, he was given a single agent adjuvant chemotherapy in the form of 5-FU, 1000 milligram per meter square, day 1 to day 4. And after 4 cycles, even the 5-FU was stopped because he developed COVID. Now, after 4.5 months of CTRT, when we've done a repeat PET scan for him, we found that he has a residual left-sided lymph node is there. And also there was a small area of FDG avidity in the nasopharynx as well. So we did a nasopharyngoscopy, which also showed that there was a erythematous patch in the left nasopharyngeal wall, and the biopsy was squamous cell carcinoma. So CTRT and adjuvant chemo done, and now he has a residual disease in primary as well as neck node. We did a correlation of this PET scan with our volumes, and both these neck node and the primary was within the 70 gray volume. So the few questions are, what is the intent of treatment now? Is it palliative or still is it a radical intent? Should we label this patient as platinum refractory? What are the systemic therapy options and the role of immunotherapy? So I think I will straight away go to Dr. Kumar Prabhash and Dr. Sahu for this case.
So, residual disease is, this is a very peculiar scenario that patient has responded. If we take it palliative, for example, if we can remove it, great. If we can't, systemic therapy, and radiotherapy, they have done their job, what maximum they can do. Can we do beyond this? Have this patient has been taken in the study? They have been, but not specifically this group of patients. Think about 8 centimeter tumor becoming 2 centimeter. And now also if the intent is palliative, the good palliation has happened. Now if patient is asymptomatic and are having a residual disease, and if I can't remove it, whatever treatment I give, what has been given may not palliate the patient further. Now, can we have a treatment to increase the life? Now, that can be a debate. And then how much life increase is there? Now, one data is very promising. That is the gemcitabine platinum versus 5-FU platinum data. That is very promising. But that has not been replicated. That 5-year survival of around 27-28% in nasopharynx, but that has not been replicated. So that if I see that, then I say, oh, I'll give some treatment. Otherwise, if the intention is palliative, good palliation has happened, residual disease is there after treatment, sure, I will consider further RT or further systemic therapy if the disease increases further. That will be my opinion, because this not only we see in this situation, this we see a lot in our other sites, oropharynx or larynx and hypopharynx, and then always have this debate. Now, do you want to, if you can't remove the tumor, now do you want to give palliative systemic therapy in that setting? So for me, good palliation has happened. In case now intent becomes palliative, keep good observation or surveillance, see if the disease increases, see if the symptom increases, and then we need to consider that time for palliative systemic therapy or local therapy. Or that time, think about if disease doesn't increase for a year or two, we may again consider some local therapy at that time. But again, this is my thought process. Will like to hear from others.
Vineeta, can I say something here?
Please.
See, because this is nasopharyngeal cancer, I would suggest something else. And 4.5 months, and I think Kumar is quite correct in not labeling this man as platinum refractory, because a node has almost become, you see the size of the node, there is a remarkable reduction in the size of the node. And also the disease that you see in the nasopharynx is hardly anything. I would actually send this patient across to the surgeon just because it's a nasopharynx. And even now, after 4.5 months, you have no evidence of metastatic disease. So I think it may be worthwhile not labeling him as palliative just now, not yet. And please take your surgeon's opinion, whether he can do some kind of a resection for the nasopharynx, as well as, because with the better endoscopic surgical tools that are available for nasopharynx also. It is possible today to undertake resection, and also the node looks resectable for a salvage neck dissection. Of course, things would have been easier if we didn't have the residual disease at the primary. But the point is that even the residual uptake at the primary, or because you've got a 4.5-month gap, if you could do brachytherapy. This is another case where brachytherapy can be used in nasopharyngeal cancer, providing your surgeon is willing to undertake neck dissection. This is one place where you could boost with further radiotherapy, with brachytherapy or an SBRT boost. These are typically the series in nasopharyngeal cancer where they've considered doing SBRT boosts or brachytherapy boosts in today's day and age, so you could consider these options, but I would first send it to the surgeon.
I can see a smile on Dr. Wasim's face. He has been after me to give radiation again. And I have been, but I think the point that Dr. Sarbani has made did not come to my mind, that she said we can consider brachytherapy or SBRT boost, but after taking a surgical opinion. I think that is the advantage of having so many people, in panel and masters, like, all the faculty that we had today. I think we had a wonderful discussion. Yes,
if we are boosting,
yes.
like it came to my mind also because it was so mucosal that brachy could be done. But if we are boosting within 4.5 months of the primary treatment, what would be our dosages at this time?
Yeah, so here you won't do your classical boost dose of, so typically in TMH, when we used to use brachytherapy as a boost after CTRT for this kind of, not this kind of disease, the nodes were much smaller, they had responded and all that. So we used to use a typical 4-in-3 or something, but here you could use a 4-in-3 because you've got a gap. But the only thing, if you're using the classical Rotterdam nasopharyngeal applicator, you will have to see the dose to your palate, because that's what's going to be your dose limiting structure here, okay? But if you do an SBRT boost, again, you could conform very well to the volume. But if you're using the Rotterdam applicator, please, because if you've got the nucleotron Rotterdam applicators, which are just 2 balloons, it's a little bit of a problem. The other Rotterdam applicator increases the dose to the palate. So you have to check the dose to your palate when you're doing brachytherapy here.
Thank you.